Hello and good evening to everyone, and welcome to this online webinar on biomarker testing and oncogene-driven lung cancer, organized by Lung Cancer Europe. My name is Alfonso Aguaron, and I will be moderating today's session. Today, it is my pleasure to introduce you to Dr. Enriqueta Felip, Section Chief of Medical Oncology Department and Head of Thoracic Oncology at Vall University Hospital, and head of the Head and Neck Cancer Unit at the Vall Institute of Oncology in Barcelona. So Dr. Felip, on behalf of Lung Cancer Europe, I would like to thank you so much for your kind acceptance to lead this session on such an interesting and hot topic for the lung cancer community, and for sharing with us your valuable time today. So before we get started, I would like to explain the webinar dynamics. The session will last about an hour. So during the first part, Dr. Felip will provide a comprehensive review of this topic, which will last between 30 to 40 minutes. And then you will have the opportunity to make your questions. There are two ways to do so. So the first way is by using your microphone. So to do so, please click on the raise hand icon on the bar of the application you just downloaded to join the webinar, and I will unmute you when it is your turn. In case you prefer to do it in writing, just type your question in the Q&A or in the chat window, and I'll read them to Dr. Felip. So without further ado, I wish you all a very fruitful and interesting session, and Dr. Felip, I give you the floor.
Thank you, Alfonso. It's a real honor for me to participate in this session, so thank you for the opportunity. And I'm going to review the situation, the need of biomarkers in lung adenocarcinoma. You can see here my disclosures. So the reality in cancer is that major advances in precision medicine have changed the landscape. We know that we are in a new era of personalized medicine. We know that cancers are not all the same, even those in the same tissue. There is a need for a tailored approach, and the idea of precision medicine is to test every patient's tumor, find the mutations or molecular alterations that have become essential for it to survive, and then select the targeted agent. And we know that we have two different kinds of biomarkers. We have prognostic biomarkers. The prognostic biomarker identify patients with different outcomes of the disease, regardless of treatment. And then we have predictive biomarkers. And the predictive biomarkers may help to identify patients who are more likely to benefit from a specific treatment. And today, I'm going to discuss predictive biomarkers in lung adenocarcinoma. And I think everything changed in 2004 when two independent groups published simultaneously that in the tumors from patients with lung adenocarcinoma, they were able to find an EGFR mutation. And for those patients with EGFR mutations, the response rate to EGFR TKIs, mainly at that time was gefitinib or erlotinib, was very good. So this was a change because before 2004, we treat all patients with EGFR TKI without knowing the molecular alteration. So these two groups described in April 2004 that EGFR mutations were present in approximately 15% of lung adenocarcinomas. And importantly, in these patients, the response rate when used EGFR TKIs, oral drugs, were approximately in 70% of the cases. The next step was to compare in the first line treatment of patients with stage 4 disease and EGFR mutation, the previous standard treatment, chemotherapy, versus an EGFR TKI. And we have seen that in this group of patients with EGFR mutations, the EGFR TKI agents improve progression-free survival, response rate, and also quality of life when compared to chemotherapy. But also, it was noticed that after a time of receiving the treatment, in some patients, the disease progressed. And also, when we have done a rebiopsy in this tumor, it was detected a mechanism of acquired resistance. That was the T79M mutation. And also in 2010, we knew that at the progression of first and second generation EGFR TKIs, approximately 60% of the patients had a secondary mechanism of acquired resistance that was the T79M mutation. And this was very important because there was a number of efforts to develop agents against this molecular alteration. And this is osimertinib. Osimertinib is a EGFR TKI that is inhibiting the activating mutation, but also the T79M mutation, the mechanism of acquired resistance in 60% of the cases. And the next step was to compare in the first line of patients with EGFR mutations, osimertinib versus the first or second generation EGFR TKI. And in the trial, we have seen that osimertinib improved progression-free survival and overall survival when compared to first or second generation EGFR TKIs. We know now the mechanisms of acquired resistance when use osimertinib in first line. We know that there are approximately 10% of the patients with secondary EGFR mutations, 2% with HER2 amplification, and we have 15% of the cases with MET amplification. And knowing these mechanisms of acquired resistance may well help us to decide the sequential treatment strategies. And in fact, these are the recommendations of this group of investigators published in Journal of Clinical Oncology. The first treatment, first-line treatment for patients with EGFR mutations in general now is osimertinib. And at disease progression, there is the recommendation to perform a rebiopsy if possible, and if not, a liquid biopsy to detect the mechanisms of acquired resistance, and then trying to give personalized therapy even in the situation of progressing disease. And the guidelines now mention that there is a need for determination of EGFR mutation in a stage 4 lung adenocarcinoma, and the first line treatment should be an EGFR TKI, no chemotherapy. The second biomarker described in lung adenocarcinoma was ALK. Again, we are discussing today predictive biomarkers. ALK was present in approximately 5% of non-squamous cell carcinoma patients. In this case, ALK was described in lung cancer tumors in 2007. ALK is most frequently seen in adenocarcinoma histology, is associated with never smoker habit and younger age diagnosis, and importantly, these molecular alterations are mutually exclusive with other oncogenic drivers alterations. And the development was really impressive. As we mentioned, this was first described in lung cancer tumors in 2007. The first agent developed was CRSAtinib in this group of tumors, showing a response rate in more than 70% of the cases. And subsequently, we performed the randomized trial in first line comparing CRSAtinib versus chemotherapy, the previous standard of care, and showing that CRSAtinib improved progression-free survival, response rate, and importantly, again, was associated with better quality of life. And then now we have second-generation ALK inhibitors, alectinib, brigatinib, ensartinib. All of these trials have shown longer progression-free survival when compared to CRSAtinib, and importantly, these agents are active also in presence of brain disease. And there is also a third-generation ALK inhibitor, lorlatinib, and also we review the response rate in patients previously treated with at least one prior second-generation ALK inhibitor, alectinib, brigatinib, or ceritinib. In this group of patients, even in presence of brain metastases, the intracranial response rate was seen in 56% of the cases. And again, we have the guidelines, and the guidelines mention that there is a need for ALK translocation determination in a stage 4 lung adenocarcinoma. And if we have this alteration, again, a standard of care is an ALK inhibitor, is not chemotherapy. And also now we have the recommendation to give a second-generation ALK inhibitor. ROS1 is also a predictive biomarker. In this case, ROS1 was first described in non-small cell lung cancer in 2012. Is really uncommon, 1 to 2% of lung adenocarcinomas, and also the characteristics are similar of what we have observed in ALK-positive patients. Adenocarcinoma histology, younger age diagnosis, and never or light smokers. And again, CRSAtinib is also a ROS inhibitor, and based on a phase 2 study, including 53 patients, CRSAtinib was approved by FDA and EMA. Response rate was seen in 70% of the cases, and the median progression-free survival, 19.3 months. Again, we need the determination of ROS1. If we have this alteration, there is the recommendation of treatment with a ROS inhibitor. And there is also the presence in patients with lung adenocarcinoma of BRAF mutations, the BRAF B600E. These represent approximately 2% of lung adenocarcinomas. And again, there is a combination approved by EMA and FDA, the combination of dabrafenib, trametinib, that show in this group of BRAF B600 mutation very good response rate and a median PFS of 14 months. And again, this should be considered in presence of this molecular alteration. And these are the ESMO guidelines, again, showing that in presence of the BRAF B600 mutation and a stage 4 lung adenocarcinoma, the combination of dabrafenib plus trametinib should be considered. This is a standard of care, but when we discuss lung adenocarcinoma, we have other molecular alterations that may well be of relevance. We have mentioned EGFR mutation, ALK, ROS, and BRAF, but now we have also agents approved in the presence of MET exon 14 skipping mutation, approximately 3% of the cases. We have very good results with RET inhibitors in patients with RET rearrangements that represents 2% of all lung adenocarcinomas. And recently, even EMA has approved a KRAS G12C inhibitor for patients previously treated with chemotherapy. And KRAS G12C represents approximately 40% of the most common molecular alteration in lung cancer, that is KRAS, and approximately 13% of all lung adenocarcinomas. So testing is relevant, and in this way, 5 years ago, we used to test first one marker, then another one, and then another one in a sequential way. We have the technology of NGS, next generation sequencing technology, that allows to test different alterations in the same time. And there is the recommendation from ESMO to use NGS technologies in advanced non-squamous non-small cell lung cancer. And the reason for that is that we need a number of molecular determinations with a level of recommendation 1, including the determination of EGFR mutation, ALK rearrangement, MET exon 14 skipping mutation, BRAV B600, ROS1, NTRK, and RET. And probably in the near future, KRAS G12C and HER2 mutation. And we need to test in tumor, but in lung cancer, it is important also to have access to liquid biopsy. In liquid biopsy, the objective is to perform the molecular determination in the free DNA that we are observing in the plasma. And this is really important in patients with lung cancer because we need a number of cases that the tumor sample is rather small at diagnosis for performing NGS technologies. And we know that if we have the results of this molecular alteration in liquid biopsy, we may use these results to treat the patients. And also another potential advantage is the turnaround time that is shorter when we analyze the plasma NGS and when we compare to the tissue NGS. So ESMO recommend, as mentioned, NGS technologies in the case of advanced non-squamous non-small cell lung cancer. It is recommended that a tumor or plasma sample from a patient with advanced non-squamous cell carcinoma is profiled using NGS technology in order to detect level 1 alterations, and this is really important. We have also a biomarker for immunotherapy. It was really important, this trial, the Keynote 024. In this trial, published in 2016, patients with a stage 4 with PD-L1 50% or higher. PD-L1 is an immunohistochemistry that may well help us to decide those individuals who most benefit from immunotherapy. So in this trial, patients with PD-L1 50% or higher and without activating EGFR mutations or ALK were randomized to receive immunotherapy, pembrolizumab, or chemotherapy. Why the use of PD-L1 as a biomarker, 50% or higher? This was based in a phase 1 trial, including almost 500 patients with non-small cell lung cancer, and we have seen that for those with PD-L1 50% or higher, the response rate with immunotherapy was 45%. For those with PD-L1 between 1 to 49%, the response rate was 16%, and for those with PD-L1 negative tumors, the response rate was 10%. And this is the way the cutoff for this biomarker was selected. And you can see here in the first case, in the first column, this is a negative tumor. You can see here PD-L1 between 1 to 49%, and in the this column you can see a PD-L1 50% or higher. That means that more than 50% of cells stain for PD-L1. And with this criteria, the study was clearly positive, and in the presence of PD-L1 50% or higher and negative EGFR or ALK, pembrolizumab improved survival when compared to chemotherapy with a hazard ratio of 0.62. And there were clear differences at 60 months. And let me just finish by a clinical case from our institution. This is a 86-year-old woman, never a smoker, without history of disease, no comorbidities, and in November 2018 started with dyspnea, and a thorax and abdomen CT scan was performed showing bilateral disease. So the symptoms included grade 2 dyspnea related to the disease. And you can see this is the CT scan, and you can see the disease in both lungs. When we explore this patient, the patient had a supraclavicular lymph node. We decided to perform echography plus a fine needle aspiration. The result was an adenocarcinoma tumor, and also the pathology report showed an EGFR activating mutation. And the patient started with an EGFR TKI, and after 6 weeks of treatment, a partial response was achieved. There was a clear partial response in the radiological assessment, but importantly, there was clear symptomatic improvement. And at present, the patient is following the treatment with an excellent tolerance and quality of life 3 years from the diagnosis. And let me just by finish that we need precision oncology in lung adenocarcinoma. The genotyping increases the chance for overall survival improvement. It's important to perform, and the recommendation now is to do NGS technology, enabled to detect not only one alterations, but also all the alterations in a concomitant manner that we need for the treatment. There is in some way also the need to have access to liquid biopsy, but yeah, it's important to have this kind of meetings, but we have still challenges, no? Genotyping and also available treatment options when we detect these molecular alterations, and the only way to improve this is to work together. So thank you so much for your kind attention, and I would be very pleased to discuss any aspects you may consider.
So thank you very much, Dr. Felip, for this very comprehensive review. I think it's been a very great presentation, and I'm pretty sure that our audience has found this useful. Indeed, we have already received some questions that I will pass now to you. They are in writing, but I would like to remind our audience that if you would like to make your questions now, you have two options to do so. First one, by pressing the raise hand icon if you would like to do your questions by using your microphone, and I will unmute you, or you can use the chat window or the Q&A window to type your question, and I'll read them to Dr. Felip. So I'm just going to start with the first questions, which says, it seems that some national health systems are still reluctant to include molecular testing panels in their baskets. So what do you think the reasons are, and do you expect the situation will be improving in the future, especially in the smaller hospitals and care units with not a large experience in treating lung cancer?
Thank you for the question. That is very important. I think the situation is now changing. I mentioned during my presentation that we need NGS technology in patients with lung adenocarcinoma. I understand that it's impossible to perform NGS in all institutions, and I think it's not the way to go. We need to detect those central labs in which we need to centralize this determination of these molecular alterations. And this is, for example, what we are doing in Spain. And there are some examples, France, Germany, that, you know, this is a reality. And I think this is something that is changing in Europe. So yeah, I think it's an important question. We need to monitorize what is the situation, but the feeling is that yes, this is changing, and yeah, this is what we are seeing also in Spain. We have a meeting March 16 to discuss this, how to implement these NGS technologies. I think in Europe in general, the patients are tested for EGFR, ALK, and ROS, but yeah, we need this new step, that is determination using NGS technologies. Thank you for the question.
Thank you so much, Dr. Felip. Indeed, I'm going to read it. It was not received in you know, it was one of the last questions, but it's very related. So I'm going to go with these questions that one of our attendees just sent, and it is related to the answer that you gave, so it may help to extend. So it's, to my understanding, not every center will have the technology to perform NGS. So how do you see this as a source of inequity for patients in terms of having an accurate diagnosis?
Sorry if I misunderstood the question. So what I mentioned is that there is no need to perform NGS in each of the hospitals. It's clear that all patients need the results of NGS. So we need to work together to have central labs in which all centers can send the tumor tissue. I can explain what are we now doing. For example, I'm working at Vall Hospital, and my hospital is a reference center, but here we are receiving tumors from other institutions. And we have together a molecular tumor board that is Friday at 8, and we discuss all together the results, the physicians from the different institutions. So it's clear that all the patients need the results to have NGS. It's true that performing NGS probably should be done only in some centers, because there is a need of technology, there is a need of bioinformaticians, and also quality strategies.
Okay, thanks, Dr. Felip. So next question is, are there any findings in the presence of certain biomarkers in small cell lung cancer that can lead to the development of a targeted therapy for patients that diagnosed with this disease subtype?
Thank you for the question. I think in small cell lung cancer, now we don't have any clear biomarker to determine in order to individualize the treatment. But yes, we need to investigate more, because this has been a clear change in lung adenocarcinoma, and yeah, we need to investigate in small cell lung cancer also potential predictive biomarkers. But this is not the reality now. So there is not need for a standard determination of biomarkers in small cell lung cancer.
Thank you so much. We still have a few questions left. Just remind that we can still receive some questions from your side. So next question is liquid biopsy sensitive enough compared to tissue biopsy?
Thank you for the question, important question. When we discuss also liquid biopsy, we are discussing a lot of different technologies, okay? So it's true that we need to know the sensitivity of liquid biopsy technology that we have used. In general, I think the agreement is that a diagnosis, if it's possible, it's better to have tumor analysis. If there is no enough tumor tissue, liquid biopsy may well be an alternative, but it's true that the sensitivity is slightly lower. So we can miss some positivities using only liquid biopsy. But there is another situation that we mentioned, that is a disease progression. And sometimes, you know, performing liquid biopsy is also relevant in that situation. But yeah, I would agree that the liquid biopsy in general, the determinations are less sensitive when we compare with tumor biopsy. But on the other hand, if we have a biomarker that is positive in liquid biopsy, we can use to treat, okay? But if negative, there is no biomarker, one possibility that is no shedding, we need to perform a rebiopsy in order to be sure that there is not a positive biomarker. Thank you for that question.
Thank you very much, Dr. Felip. Another question here. So it's, do you find regularly severe toxicity effects that lead to suspension or termination of treatment when using targeted therapies? And this person is also asking, is this affecting the choice of a second or third generation of TKIs for treating the patient?
Toxicity is always relevant. I think there is a need for a clear discussion about the different treatment options and you know, the toxicity we may see with each of the agents. And yeah, one of the important aspects that we consider is the percentage of patients who definitively stop the treatment due to toxicity. And this is something that we need to discuss in each situation in an open way with the patient in order to select the best treatment strategy. It's really important, the toxicity, yes.
Nice. That's very clear. That's good. So we still have 3 questions left. Just as we still have time, if our audience would like to see more, we're still on time to have them pass. So next one is why PD-L1 is treated with immunotherapy and the other mutations are treated with TKIs. I think this is a question related to expression and biomarkers. So yeah.
Thank you for the question again. I think in the last 15, 20 years in lung adenocarcinoma, we have made a lot of progress in 2 different lines. One, treatment according to molecular alterations, EGFR, ALK, and ROS, and immunotherapy. It's true that in the scenario of EGFR mutation, ALK, ROS, there is not very high sensitivity to immunotherapy in this population, okay? So in general, if we have an EGFR mutation, ALK rearrangement, or ROS, we need to treat the case with a targeted drug, not with immunotherapy, okay? In general, immunotherapy, that is also a very nice strategy and now a standard of care in a lot of scenarios of lung cancer, is mainly used for those population without EGFR and ALK alterations. And in the study that I presented, EGFR mutation and ALK positive individuals were excluded due to this situation. So immunotherapy is very active, but mainly in those patients without these molecular alterations. And we have now 2 strategies: monotherapy with immunotherapy, mainly for those population with PD-L1 50% or higher, or the combination of chemotherapy plus immunotherapy.
Great, thank you. A couple of questions left. Next one seems to be a complex one, and this person wants to know your opinion. So he's asking, as the understanding of lung cancer biology is improving, it seems that we are knowing more and more specific and rare mutations with a higher degree of complexity and poorer results, like exon 20 insertions other point of the lesion mutation. So from your point of view, are you optimistic with research landscape of targeted therapies for these rare types, or do you think that research efforts should be focused on finding alternative ways to treat these mutations?
I think one of the, thank you for the question again, very important. I think it's important to understand cancer in general. It's important to understand cancer. You have referred to exon 20 insertions. We know that these molecular alterations are not particularly sensitive to first or second generation EGFR TKIs, but we have now other agents that may well be or may have activity. It's true that we need to understand these molecular alterations, and perhaps in this group of alterations, there is not the need to give targeted agent alone. Perhaps we need to give concomitant with chemotherapy. Also, could be important to know the potential role of other concomitant molecular alterations, such P53. So again, it's relevant that we understand the cancer better, and to give the opportunity in the future to personalize more the strategies. But yes, probably there are some molecular alterations that a targeted agent may well be not enough, and we need combinations.
Thank you so much. So it seems we have a person that has raised her hand. So it's Pilar. So Pilar, I'm going to unmute you. So I think you have to unmute yourself as well, just in case you would like to. Oops, it seems that she got disconnected. Okay, so I'll go with the next question. So Pilar, if you rejoin the call, or I will give you the floor. So this last question, I'm not sure whether I understand this correctly. So the person says, how available are the drugs to patients for those that have the analysis done? I understand that this is about the situation of access, especially with these innovative treatments. So I will ask you about your perception about how the level of access is. I know you are working in Valdebrón, but probably you are related, you are connected to some of your colleagues across Europe. So if you would like to express your point of view on how do you see the future of access to patients to these innovative treatments, this would be great.
No, thank you. Again, very important. I think was one of my comments in the last slide. No, we need to yes, ensure access and the situation, because it's true that the investigation is doing really quickly, and we know, for example, that there are some promising drugs in some molecular targets, and these agents are not approved. So yeah, I think working in clinical trials in expanded access programs together with the pharma industry is really relevant. So it's an important topic to work all together. It's true that there are some of these efforts, no, expanded access programs that allows to treat the patients even before some approvals, but yeah, it's relevant.
Seems I think it's one of the key challenges, and here at LuCE we are having a few projects as initiatives to really understand better the current access scenario and really advocate for better access for patients. So I can see that Pilar has rejoined, so I'm trying to unmute her again and see if she can make the question. So Pilar, I think you need to also click on the unmute unless, or yeah, here you go. I think we can hear you. Pilar, can you hear us?
Yes, I can hear you.
Great. So you can make the question to the doctor.
Okay. I wanted to know if you have thought about mixed combinations of drugs, different drugs, immunotherapy with TACI. Do you think about this? These two together could work good for us, for patients with biomarker?
Thank you for the question, Pilar. It's an important question also. It's true that we have some experience of the combination of, for example, EGFR TKIs plus immunotherapy. What we have seen in EGFR mutation and ALK is that the combination of TKIs plus immunotherapy was highly toxic and in general do not improve the outcomes in this scenario, okay? But perhaps this could be something different in other scenarios. It was, for example, I was thinking, for example, the KRAS G12C molecular alteration. So I think not all the alterations are exactly the same. We know now that in case of EGFR mutation and ALK, this is not clearly working, okay? But yes, I think there is a need for more investigation to that. And not only with immunotherapy, but also with other combinations. I think the combination will be the way to go, and we need to put together probably agents targeting different pathways of the cell. So yeah, combinations will be really important.
Thank you.
Thank you, Pilar.
Thank you so much, and thank you, Pilar, for that question. So it seems that there are no any other questions. So unless there is a latest one, it doesn't seem so. I'm going to proceed with closing the sessions. And before closing, I would like first to thank you again, Dr. Felip, for such an outstanding presentation, for your kindness answering all these questions from our audience. And I'm pretty sure, because we have been receiving some thank messages to you, that the audience has been very happy with what you presented. It was very clear, even though it's a very complex topic at the moment, but it has been of the interest of our audience. And yeah.
I would like to thank all of you for being connected. Thank you. It's a real honor for me. And thank you, LuCE, for all your work always. So thank you, and it's a pleasure.
Thank you, Dr. Felip. And also I would like to thank you all our attendees today for being with us today. I would like to remind that the full content of this session has been recorded and that it will be uploaded to our YouTube channel in the coming days. And as an effort that we're making for LuCE to have these contents spread as much as possible, we will also have the subtitles available in French, German, Italian, and Spanish. So I kindly ask you to share this with anyone who might be interested in the topic, so we can reach the higher number of people possible, especially people living with the disease and their caregivers and so. Being said that, I encourage you to follow us in our social media channels like Facebook, Twitter, LinkedIn, and Instagram. Check our website, which is www.lungcancereurope.eu, and to subscribe to our newsletter to receive the latest updates on our projects and activity. With that being said, I would like to wish you all a very good evening, and I look forward to meeting you all in our next session. Thank you again, Dr. Felip, and goodbye to everyone.
Bye-bye.